Good afternoon. My name is Dr. Julie Barr, and I'll be co-moderating this session along with Dr. Joanna Stollings. The name of the session is Resuscitating the ICU Liberation Bundle Following the COVID-19 Pandemic. I have no financial conflicts of interest to disclose. And before we begin our presentations, I have a few housekeeping notes. Please move to the center of the row and fill in all seats. Do not save seats or store your personal belongings on the seat next to you. If there's no one on either side of you, feel free to stretch out and nap. Please note the location of the exit doors. It's not so important that you can run fast as long as you can outrun the slowest person. Please silence your cell phone. And if you wish to leave this session for any reason, do so at your own risk and exit quietly. And make sure you cover your name tag up. Once the session is concluded, please exit quickly as the next session will follow this one immediately. If speakers and attendees would like to continue to discuss the topic, please go to one of the designated Continue the Conversation areas outside the ballroom on the lower second and third floor. Full Congress attendees will gain access to Congress digital content for continued learning, and information about CE credit is available on the Congress app. Speakers should disclose any conflicts. Please do not publish digital photographs of slides displaying the no social media icon into the public domain. And be mindful that while social media provides an open-air forum for the presenters, conference attendees, and the public, good manners and respect should prevail. Plus, we know where you live, and we will come and find you. Before we begin our presentation today, I just want to let you know that we're going to present all 6 bundle elements in succession. So please hold your questions to the end, and then we'll have a singular Q&A period. Before we hear from our first presenter, I wanted to take a few moments to provide some background and context for these presentations today. When I began my career as an intensivist over 30 years ago, the standard of ICU care was deep sedation and prolonged mechanical ventilation for our sickest patients until they got better. Over time, we have come to understand that deep sedation and immobility comes at a price and actually worsens ICU patient outcomes, resulting in delirium, ICU-acquired weakness, prolonged mechanical ventilation, hospital-acquired infections, DVTs, pressure ulcers, and longer ICU and hospital length of stay, along with worse long-term outcomes and death for many of our patients. Prior to the pandemic, 50 to 75% of ICU survivors were often plagued by long-term physical and cognitive dysfunction and mental illness, collectively referred to as the post-intensive care syndrome, or PICS. Patients with PICS are less likely to return to their previous level of functioning and employment, are more likely to be discharged from the hospital to a skilled nursing or rehab facility, have higher hospital readmission rates, and higher mortality rates at 1 and 5 years after hospital discharge. These patients may have survived their ICU stay, but they are far from fine. Then a decade ago, the Society of Critical Care Medicine published the PAD guidelines, which took a more holistic approach to pain, agitation, and delirium management in order to facilitate ventilator weaning and mobility efforts in patients. In 2015, the ICU Liberation campaign was launched by SCCM, and the ABCDEF bundle was created to help clinicians translate these guidelines into clinical practice. The A through F bundle focuses on optimizing pain management, minimizing deep sedation using non-benzodiazepines preferentially, and discontinuing sedation as early as possible, aggressively weaning patients from mechanical ventilation, preventing and treating ICU delirium, and getting patients out of bed even while intubated, and engaging patients and family members in their care. In 2018, an updated version of these guidelines were published known as the PADIS guidelines, which provided additional recommendations around promoting sleep and mobility in critically ill patients. The effects of the ABCDEF bundle have been studied in several large multi-center trials. The largest of these was the ICU Liberation Collaborative, which included over 15,000 adult ICU patients. The results of this collaborative showed that bundle performance improved ICU outcomes across the board in both mechanically ventilated and non-mechanically ventilated patients. Bundle performance also had a dose-response effect on these outcomes, with around 60% bundle performance levels resulting in accelerated improvement in outcomes. Shea and colleagues have demonstrated significant ICU and hospital cost savings associated with only partial bundle performance. A more recent study by Fish and colleagues also demonstrated significant improvements in ICU and hospital outcomes with considerable cost savings over a 5-year period following bundle implementation in a single 24-bed adult med-surg ICU at an academic medical center. They noted significant reductions in the duration of mechanical ventilation, ICU and hospital length of stay, while patient acuity and the number of mechanically ventilated patients actually increased. This translated to a cumulative savings in hospital costs of over $4.3 million over a 5-year period. Just think of what your hospital could do with an extra $4.3 million. The goal of ICU Liberation is to ensure that all ICU patients receive the A through F bundle every day in order to improve the care and outcomes for all critically ill patients. For the first 5 years of the ICU Liberation campaign, ICUs were making modest but steady progress towards achieving full bundle implementation. But in 2020, the rapid onset of the COVID-19 pandemic demonstrated the worldwide vulnerabilities of hospitals and critical care delivery systems. In the first year of the pandemic alone, 80 million people had been infected with the SARS-CoV-2 virus across the globe, and 1.7 million people had died. During the same period, approximately 1.5 million COVID patients were admitted to ICUs worldwide, with half of these patients requiring mechanical ventilation for viral pneumonia and ARDS. ICUs were quickly overwhelmed with more patients needing ICU care than critical care beds, resources, and trained staff available to care for them. The delivery of critical care medicine became a lesson in disaster medicine, with ICUs doing the best they could to triage and stabilize patients with few effective treatment strategies available. Many of these COVID patients were often intubated, mechanically ventilated, and deeply sedated and paralyzed for weeks, developing common complications from severe critical illness, including delirium, ICU-acquired weakness, infections, DVTs and pressure ulcers, ventilator dependency, and death. 30% of these patients initially died. More than 75% of COVID patients who survived to hospital discharge were plagued by symptoms of PICS and long COVID. Public health experts warn that PICS and COVID-19 survivors may be the next public health crisis we face in the wake of the pandemic. Predictably, the A through F bundle performance plummeted during the pandemic. In 2020, an international ICU survey of A through F bundle practices demonstrated that routine pain assessments were performed in less than half of these patients. SAT-SBT trials and routine sedation and delirium assessments had decreased by 50% from pre-pandemic levels. Patients were routinely mobilized in only 35% of cases, and family engagement occurred in only 16% of cases. To date, there have been over 660 million cases of COVID-19 worldwide, with 1 in 10 patients dying from COVID infections. And the demand for ICU beds continues to ebb and flow. As we slowly emerge from the shadow of the pandemic, we face new challenges to ICU Liberation Bundle performance, including ongoing staffing shortages, a loss of expertise and institutional memory around the bundle due to staff attrition, new hires with no prior bundle knowledge, training, or experience, staff burnout and low morale, a lack of teamwork and leadership support for the bundle, incomplete integration of the bundle into electronic health records, and new infectious disease challenges. The goal of this session today is to help all of you to resuscitate ICU liberation in your ICUs in order to improve patient outcomes and reduce healthcare costs. But perhaps most importantly, ICU liberation also gives clinicians, patients, and families hope that patients will not only survive their ICU stay, but also achieve a meaningful recovery. By the end of this panel today, you should have a better understanding of the impacts of the COVID-19 pandemic on ICU liberation performance and how to reinvigorate the ABCDEF bundle in your ICUs. We have an all-star lineup of panelists here today to share their expertise and pro tips for improving ICU Liberation Bundle performance in your units. Our first speaker is Dr. Michele Balas, Associate Dean of Research and the Dorothy Hodges Olson Distinguished Professor of Nursing at the University of Nebraska Medical Center College of Nursing. She is also the co-chair of the SCCM PADIS Rapid Update Committee. Dr. Balas.
Good afternoon, everybody. You guys all get a gold star for being here while all the great NFL games are on. Go Eagles. Well, welcome to this presentation. I have the honor of talking to you about resuscitating the letter A, so the assessment, prevention, and management of pain. As Dr. Barr mentioned, the challenges that we're facing in the ICU right now are very real, impacting everyday care, in particular the challenges that we're having with nurse staffing and the influx of new graduates that we have in our ICU, the use of travelers, and inconsistent staff. One of those challenges will be getting everybody reinvigorated to follow the ABCDF bundle as best they can, but most importantly, really focusing back on the basics of what we know works. So for the next 10 minutes, not to ruin the surprise, but what I'm going to emphasize with you is what we know that works. So the previous versions of the ICU Liberation guidelines and the A through F bundle publications that we have, the knowledge that we developed over the last 10 years, really bringing you that evidence so that you can then distribute to the colleagues that you work with and your institutions. So when we're talking about the letter A, we are referring to the assessment, prevention, and management of pain. And when we do that, the first step is assessing pain. And for the assessment to be good, we all have to come to the common agreement that the gold standard of pain assessment is still the patient's self-report. Pain is truly a subjective experience, and I know many of my colleagues would love to have some kind of objective or omic approach to measuring pain. Right now, we don't have that ability. Hopefully, maybe in the future we will. But again, pain is what the patient tells us it is. So when we're assessing for pain, one of the things that we really do want to remember, and it's been tough over the last few years with the COVID-19 challenges, is really engaging our family members. Now that some of our hospitals are letting them back at the bedside, really engaging them in assessing pain. They, again, are the gatekeepers and most knowledgeable about the patients and can give us some hints into what the patient presented like beforehand when they were having pain. The guidelines suggest, and the ABCDF bundle has operationalized how often we should do these pain assessments. And the suggestion is that we're doing them at least 6 pain assessments. per day using a valid, reliable tool, and nothing new here has changed. Again, we're going to be focused on using that numeric pain rating scale for the patients to give us their interpretation of their pain levels. But for those patients that are unable to give us that numeric value, we're going to be using tools like the Behavioral Pain Observation Tool and the CPOT, the Critical Care Pain Observation Tool. The ICU Liberation website on the SCCM has these resources available for you that you can take back for when you're doing some of this education surrounding effective use of these tools, but nothing has changed in terms of the way that we're going to be assessing patients' pain level. Another great teaching points that we like to emphasize is that it's really important to recognize that pain is common with even routine procedures in the ICU. So obviously we think of those really super painful procedures that our patients go through, the chest tube insertions, the A-line insertions, Foley catheters, things like that. But for many critically ill older adults, even the simplest nursing procedures, for example, turning on the side or repositioning that we do so frequently to prevent the pressure ulcers, that pain is a real occurrence even with those common procedures. So when we're thinking about treating, preventing, and managing pain, it's really important to kind of put on your detective hat and really think about if we need to pre-medicate patients for even some of those common daily procedures. And of course, we always want to treat pain first. So before we reach for our arsenal of sedative medications, really treating the patient's pain adequately before we use those sedatives. There are a bunch of non-pharmacologic interventions. The current guidelines suggest offering critically ill older adults things like massage. That'd be great, right? Those good old days when we had that opportunity to give our patients the massage during their baths and things like that. Music therapy to relieve non-procedural and procedural pain. That music therapy, again, being reflective of what the patient likes. Even though we might like hip-hop or rock or something like that, for the pain and anxiety relief, it's really important to make sure that the patient identifies what type of music is most relaxing to them. Using things like cold therapy and other relaxation techniques, and various other therapies like Reiki, pet therapy, family presence. Even they're not strongly supported with randomized control trials, some of your ICU colleagues have had really great success with programs that offer these different therapies in the ICU, and making that connection among ICUs is a really great opportunity to learn from others. In terms of pharmacologic interventions, you're going to reiterate that we are still going to do that assessment-driven, protocolized-based approach to pain management. So many of us have our pain protocols operationalized in nursing procedures and other guidelines that you might have at your institution. So kind of dusting off those manuals, make sure they're up to date with the recent guidelines, but really taking that protocol-based approach because we know that that works best in terms of pain management. The guidelines suggest that there are some non-opioid strategies that you can consider using in terms of pharmacologic management. You know, our good old friend Tylenol there on the top of the list there. But using these less intense medications to reduce opioid consumption in the critically ill older adults. Because then you can avoid some of the common side effects that we have with the opioids that can be equally troublesome for critically ill older adults and some of the side effects that they might experience. Again, treating neuropathic pain, neuropathic pain medicine for those patients with neuropathic pain, and using distractive and techniques like that. As Dr. Barr mentioned, we had some really great evidence that we were making some progress with our ABCDF bundle pre-pandemic, and in fact, the A in the ABCDF bundle was one of those things that we had the most success with the awesome 68 ICUs that worked with our, that participated in the ICU Liberation Collaborative. As you can see in this chart, A was actually the assessment, prevention, and management of pain was really one of the things that was one of the best performing elements in the bundle. So you see that we were really good with it before the collaborative started, and we got even better as time went on during the course of the collaborative. What's interesting, and which is kind of an optimistic thing to do, is that we also saw some really interesting variability with the element A. So we saw this great variability in terms of delivery of the bundle in general. We had a lot of opportunities for improvement in terms of the complete performance, meaning that patients get every part of the bundle every day, like we wish everybody could. But even within the different bundle elements, and in particular in letter A, you can see on this chart that there was a wide variation among ICU practices throughout the nation with the assessment, prevention, and management of pain. We suspect that some of that variation came down to the use of tools, because when we operationalized what it means to be doing the A and the A through F bundle, it was the use of those valid and reliable tools. So we think some of the intensive care units may have chosen to use tools that were not guideline recommended. But that's pretty great news. We also just did a follow-up study where we asked practicing ICU clinicians, and if you filled out the survey, fantastic, thank you so much. But now that we are coming through the worst part, hopefully, I shouldn't have said that, probably bring us back. But now that we are trying to re-emphasize and re-energize the A through F bundle implementation, what are some of the strategies that clinicians that are practicing right now say that we can do to help? And we have a really great idea. Nobody in this room is going to be shocked, but the biggest suggestion being is that we really do need those personnel and equipment resources available to providers in the intensive care unit to make the bundle implementation successful. So with the pain assessment part of it, if we're thinking about personnel, equipment, and resources, again, I think the most logical thing to do at this point is, if you're one of those units that really is struggling with a lot of new-to-practice nurses, God bless their soul, we know that those nurses were also educated during the pandemic, and that has been very challenging on them as well. But in terms of the personnel and equipment, now might be a great time to bring out those guidelines to make sure that the tools that we're using are the guideline recommendations, and maybe if you have the time and opportunity to do some of that teaching as it relates particularly to the behavioral pain scale assessments. We also know that the clinicians right now really are begging, and it's kind of surprising to me because we've worked with such high performers in the ICU Liberation, really invigorated ICUs, but clinicians want really available protocols. So they want those protocols right at their fingertips. So suggesting that however your intensive care unit is operationalizing these different bundle components, that they can have access to that so that they know in a quick way, like nobody wants a half-hour lecture. I'm glad, my part's almost done already. Today's learners really want something touch. This is what I need to do for A. This is what I need to do for B. So they want those protocols and procedures in place, but they want it delivered in a way that's very time-friendly and engaging. And they also, interestingly, are pretty pleased with the amount of collaboration and coordination of care, but we're hearing still that there's some challenges. And again, a lot of those challenges that they're expressing is related to staffing turnover and new staff on the unit. What's interesting when we looked at strategies to increase the A through F bundle and even the A bundle, there was some differences that we saw in terms, and this will be published shortly in Critical Care Exploration, but there was some differences in what both different professions thought are what is important ways of getting these elements into practice, and also differences among administration. And interestingly, one of the biggest challenges is the emphasis that clinicians really truly believe that we do need to have more investment in that manpower to make these processes happen than the administrative leaders or the C-suite. So making that connection very important. So again, probably nothing too surprising in terms of what is happening in terms of assessment, prevention, and management pain in the ICU, but that's a really great thing. It gives you the opportunities, because I assume you're all the leaders in here that were involved in the initial efforts to get the bundle into place in your units. Nothing really new has changed as of yet. We're working on the revised, updated guidelines now, but it'll give you the opportunity to pull all of these great resources that the SCCM has in terms of the bundle, and to not reinvent the wheel. I look forward to taking questions afterwards. Thank you.
Our next speaker is Dr. Neil Prendergast. Dr. Prendergast is a pulmonary critical care physician and researcher at the University of Pittsburgh. His research interests lie in delirium, sedation, and mechanical ventilation, and today he will be talking to you about how to reinvigorate the B element of the bundle. Dr. Prendergast.
Thank you so much, Dr. Barr. The blessing in cursive, being 6'2". So welcome to Part B of Resuscitating the Bundle, both spontaneous awakening and spontaneous breathing trials. As mentioned, I'm Neil Prendergast. I'm a pulmonary critical care physician at the University of Pittsburgh. And I have the honor of leading an approximately 15-minute tour of the path the field has taken over the last really 60 years. And where I hope that path will lead. I should always start with, I have no financial conflicts to disclose. So, as part of an outline, we'll start with how ICU practice came to be, particularly practice regarding sedation and weaning from mechanical ventilation. We'll follow two parallel through lines, breathing and awakening, essentially from the birth of critical care medicine to now. We'll continue to current best practices and the reality on the ground, both immediately prior to and during the COVID pandemic. And finally, we'll conclude with a glimpse into the future, or perhaps better said, into several possible futures. A few notes before we get started. I have structured this as a narrative review, using several seminal trials as signposts. And I probably will overgeneralize when I say that the field did X. What I mean is that X became more common. So, where have we been, and how did we get here? It would be reasonable to start a discussion of critical care practice in 2000 BC, when the first tracheotomy was described. But for our purposes, we'll start in the 1960s. That was when intensive care units were becoming more common at major centers in the United States and worldwide. And in particular, I'd like to start at Colorado, with the respiratory intensive care unit that was led by Tom Petty for a number of years. This unit's particularly useful for our purposes because it was set up as a respiratory intensive care unit, and so weaning from mechanical ventilation was in the forefront of the minds of leadership. Because the use of sedative hypnotic agents was rare, and because they wrote down their practices. When thinking about extubation, liberation from mechanical ventilation, everywhere was doing something a little bit different. And the group at Colorado, in search of more objective measures, performed a trial, which Dr. Petty then included in a review of their first 10 years of practice. You can see the criteria on the screen. If the patient has a resting minute ventilation of less than 10 liters, can double that ventilation or that volume on command, and can generate an instantaneous negative pressure of -30, that patient is very likely to be able to be extubated. And this turned out to be true. All 76 such patients were extubated without any reintubations, although these criteria were not necessarily the most sensitive. They left 7 of 24 on the table. And so this is the first step to protocolized liberation, but it's not really a weaning protocol. And over the next 20 years, there were multiple efforts, both on the part of critical care medicine as a discipline and on the part of ventilator companies to smooth the weaning process with spontaneous intermittent, mandatory ventilation, and pressure support ventilation in particular. However, ventilator weaning remained largely empiric until about 1995. At that time, Andrés Esteban and colleagues published a paper examining 130 patients who had had respiratory distress during an initial weaning attempt. They randomized those patients to one of 4 techniques, either intermittent mandatory ventilation with slow decreases in the respiratory rate, pressure support ventilation with slow decreases in the support pressure, or intermittent breathing trials, either once or more than once per day. And it was found, as you can see, that a once daily spontaneous breathing trial was associated with a nearly 3-fold higher rate of liberation compared to intermittent ventilation, and more than twice the rate of pressure support ventilation. And this really ushers in the era of the spontaneous breathing trial. Adding to this, the next year actually, Wes Ely and colleagues at Vanderbilt published a paper looking at basically how you decide when to start. And they randomized patients to either screening and an SBT conducted by the research staff, with the results then communicated to the treating team, or to screening alone. And similarly, as you're all aware, they found a significant difference. Patients got off the ventilator a day and a half faster in the intervention compared to the control group. Interestingly, counter to some fears, but consistent with the bulk of subsequent literature, the risk of reintubation was actually higher in the control group. You can get people off both more safely and more quickly. And so at this point, by the mid-1990s, the field has established that spontaneous breathing trials are beneficial. There's still work to do, particularly in how one performs an SBT. But for the moment, I'd actually like to switch to our other through line, awakening. As Dr. Barr mentioned, in between the 1960s and the 1990s, the practice of deep sedation was increasingly, and by mid-1990s, overwhelmingly common. A major driver was obviously the increased use of sedation, particularly continuous intravenous sedation, and that's shown very nicely from this figure, or by this figure, from a 98 paper by Marin Koloff and colleagues examining practice at Barnes-Jewish Hospital in St. Louis. Here they took patients who were receiving continuous intravenous sedation, comparing them to those who weren't. And even after matching in a cocktail proportional hazards model for obvious covariates, they found a marked difference in the duration of mechanical ventilation, on the order of 5 days on average, between those patient groups. And I include this both because it's bad, but because also it is indicative of the practice environment at the time, a fact which was bemoaned actually by one Tom Petty in the editorial that accompanied this paper. And I'll read you just a selection of his words from that editorial. "What I see these days are paralyzed, sedated patients lying without motion, appearing to be dead, except for the monitors that tell me otherwise. Why this syndrome of sedation and paralysis has emerged baffles me, because this was not the case in the past." Now, who here has flashbacks to mid-2020? The field obviously recognized this was a problem and began to move back from that high or low water mark, depending on how you think about it, starting in 2000. In 2000, J.P. Crest, University of Chicago, published a paper examining a daily sedation interruption as a way of minimizing sedative exposure in mechanically ventilated ICU patients. And the daily sedation interruption, later known as the spontaneous awakening trial, was simply that. Once a day, you turned everything off. The research staff would then assess the patient, and when the patient was awake, contact the patient's treating team. No other decisions were made. Despite that, patients were liberated from mechanical ventilation much more quickly, nearly 2.5 days more quickly. These two approaches, spontaneous breathing and spontaneous awakening, were then combined in the Awakening Breathing and Controlled Trial, or ABC trial, published in 2008. Here, patients were randomized to either a combination of spontaneous awakening, that is, sedation interruption, and spontaneous breathing trials, or simply spontaneous breathing trials alone, as that had become standard care. And even so, patients had just over 3 more ventilator-free days with the combination of SAT and SBT compared to the usual care of SBT alone. And so, as almost counterintuitive as it is, by 2008, the field had realized that this was necessary, that this was best practice. And so in some sense, we were, 15 years ago, where we are now. In those 15 years, still a lot of work has been done, and I'll go over a little bit of that before I turn to the pandemic. Much of the work on spontaneous breathing trials has focused on how to do a spontaneous breathing trial. And so, for example, do you use pressure support or T-piece? How long? This is a figure from a 2019 trial comparing, in essence, a more demanding to a less demanding SBT. So more demanding, a 2-hour T-piece trial, versus a less demanding half-hour pressure support trial. And this trial found has a ratio of about 1.5 in favor of the pressure support trials. Similarly, but not exactly the same, was a more recent trial published just last year comparing roughly 1-hour pressure support to roughly 1-hour T-piece trials in high-risk patients, that is, over 65 or with pre-existing heart or lung disease. And this study did not find a significant difference, although some secondary outcomes favored pressure support. So as a result, best practice is an SBT, probably a pressure support SBT, but no one will fault you if you use T-piece or CPAP. Inquiry into spontaneous awakening trials is mostly focused on implementation. And one example is this before-after study from Heidelberg in Germany, showing that the implementation of an SAT and SBT protocol led to a nearly 20% increase in successful extubation rate. Even so, despite good consensus that this is best practice, it wasn't universal. And this is just a reformatting of data that Dr. Barr showed, showing essentially that SATs and SBTs were performed approximately by 2/3 of physicians in the immediate pre-COVID era. Obviously, the COVID era was not kind to these practices. And so these are data similar to, but not the same as those shown by Dr. Barr. This is a worldwide survey of physicians actually focusing on non-American physicians. You can see that physicians were much more likely to prescribe sedation to mechanically ventilated patients and were more likely to use continuous sedation without a daily interruption. And these changes arose likely from a place of beneficence. Physicians were confronted with an epidemic of viral ARDS, and the tools available, particularly early in the pandemic, were proning, paralysis, and extracorporeal support, all of which necessitated, or at least strongly indicated, deep sedation and no ventilator liberation. Still, as previously presented, this has not been benign. Post-intensive care syndrome has become much more common. And so the question remains, where are we going? I presented, in essence, a history lesson because the COVID pandemic has, in some ways, been the history of critical care in microcosm. We began not sedating people much, getting them off the ventilator relatively quickly. And over time, we began to sedate people more deeply, more heavily, and keep them on the ventilator much longer. There are two possibilities. One is that COVID is special, and that our practices need to be re-examined. But much more likely is that it's not. And that what we should be doing in the future is what we have been doing in the past. Obviously, this figure should look very familiar. Not just spontaneous awakening, spontaneous breathing trials, but the whole ABCDF bundle are critical to removing patients from mechanical ventilation, minimizing coma and delirium, minimizing the use of physical restraints, and improving ICU outcomes. Thank you very much for your attention, and I'll be happy to take questions.
To move the mic down 2 feet. Thank you, Dr. Prendergast. It was lovely. Our next speaker is Dr. Joanna Stollings. She's a PharmD in the Medical Intensive Care Unit and a clinical pharmacy specialist at Vanderbilt University Medical Center in Nashville, Tennessee. Dr. Stollings is the pharmacist for the Post-ICU Recovery Center at Vanderbilt as well, at the Vanderbilt Center for Critical Illness, Brain Dysfunction and Survivorship, and the Pragmatic Critical Care Research Group. Dr. Stollings will be talking to you today about the C element of the bundle having to do with sedation strategies. Dr. Stollings.
Thank you, Dr. Barr, for that kind introduction. I have nothing to disclose. So my objectives today are going to be to describe the best practices for the management of analgesics and sedatives in the ICU, to describe how the COVID-19 pandemic has affected the ABCDF bundle, and to help provide strategies to resuscitate the letter C following COVID-19. So we'll start out with a patient case. So EB is a 57-year-old male that was transferred to the medical ICU from the CV ICU with cardiogenic shock. He has no specific past medical history. His ventilator settings, he's on volume control with FiO2 of 50%, a PEEP of 8, a tidal volume of 420, and his current medication infusions include fentanyl of 400 mics an hour and midazolam at 5 milligrams an hour. So this is a real case scenario that happened to me a couple months ago in the medical ICU. The nurse practitioner unrounds to me when I ask why the patient is on midazolam. Well, we used to use midazolam drips all the time in our COVID-19 patients, so I didn't change it. And this emoji is a really good depiction of what I look like that day. So first we're going to kind of review what's the evidence behind what we should be doing with regards to the letter C. Then we're going to move on to see what the COVID-19 pandemic really did to that, and then we're going to talk about strategies to how to repair that problem. So the 2013 Pain, Agitation, and Delirium and Pain, Agitation, Delirium, Early Mobility, and Sleep Statements and Recommendations say the following. The depth and quality of sedation should be routinely assessed in all ICU patients at least 4 times per shift. And we should use the lightest level of sedation that is possible. And there's really 2 different level of consciousness assessment tools that are recommended. Either the RASS, the Richmond Agitation Sedation Scale, or the SAS, the Sedation Agitation Scale. So this is the RASS, if you're not familiar with it. So a RASS 0 in general is what goal we should have for most ICU patients. They're alert and oriented. The positive numbers indicate degrees of agitation, and the negative numbers, -1 is they make eye contact to voice for less than 10 seconds. -2, they make eye contact to voice for less than 10 seconds. -1 is more than 10 seconds. -3, they respond to voice but won't make eye contact. -4, they only respond to touch. And -5, they don't respond to anything. So in general, like I said, most patients should have a target RASS of 0 to -1. If someone's chemically paralyzed, they obviously need to be -5. With the sedation agitation scale, patients, as you can see, the higher numbers indicate degrees of agitation and the lower numbers indicate degrees of sedation. And in general, we want patients to be a goal of 4 in which they're calm and cooperative. So it's important to show this data from Yahya Shahibi, which showed that deep sedation in the first 48 hours prolongs intubation. Historically, we all thought, hey, it's fine, I can sedate my patient for a couple days, right? It won't hurt anything. Wrong. Additionally, he showed that every 4 hours a patient is deeply sedated is associated with an 8% increase in risk. So once again, this really highlights why we should be lightly sedating our patients even if they need any sedation at all. And we should be discussing this every day on rounds and trying to wake up our patients. This is a secondary analysis of the ABC study that shows that nighttime sedation increases a delay in extubation. So it's thought historically that, hey, I'll deeply sedate my patient at night because this helps them sleep well, right? We all know that is not correct. And in fact, what this showed was that if we deeply sedate our patients at night, then they won't get extubated the next day because the drug is still hanging around. Additionally, the PAD and PADIS guidelines state that we suggest that sedation strategies using non-benzodiazepines, so either propofol or dexmedetomidine, may be preferred over sedations with benzodiazepines such as midazolam or lorazepam. So this is one of my favorite graphs to show anytime that I discuss sedation. So this was a study conducted by Pratik Pandahari that was published in Anesthesiology in 2005. And it shows that there is a 100% probability of being delirious the next day if your patient receives more than 20 milligrams of lorazepam. And this study has been replicated in numerous other studies, but this once again highlights why we do not want to use benzodiazepines. Unfortunately, we developed some bad habits during the pandemic, and we had to use them in some patients because they needed to be deeply sedated. We couldn't give them propofol because maybe they had high triglycerides or they had a high creatinine kinase. But this right here shows us why we should not be doing that. So this is a very good counterpoint that Wes Ely and Tim Gerard put together a number of years ago that was published in Chest. They were trying to show why benzodiazepines should not be used for sedation. So this shows all the trials that have better outcomes with propofol as compared to benzodiazepines. So as you can see, there's a number of them. These show all the trials that showed no difference. So there's a few. And these show the trials that have better outcomes with benzodiazepines. And as you can see, there are none of them. The next slide shows trials with better outcomes with dexmedetomidine as compared to benzodiazepines. There are a lot of them. Trials with no difference in outcomes with better outcomes with benzodiazepines. So once again, there are none of them showing that benzos are better than dexmedetomidine. So I added in this last slide to compare propofol and dexmedetomidine since we do have more evidence since this pattern point was published. And as you can see here, we now have two trials, and we have the SPICE-3 study and the MENS-2 study that have came out recently that don't really show a difference in outcomes looking at propofol and dexmedetomidine. And then there are a couple studies with dexmedetomidine versus placebo, and showing that with dexmedetomidine there are more ventilator-free days, and another showing decreased delirium with 7 days post-surgery. So I hope this really highlights for you why we do not want to use benzodiazepines and how we really want to use propofol or dexmedetomidine for sedation. So this is a graph or a picture that we published in a review that was submitted to intensive care medicine this past year, and really just shows how that sedation has evolved. So if you look at the very first top picture, this were the initial guidelines that came out, and this was all based on expert opinion. There was no evidence, and people were like, yeah, let's deeply sedate everyone, and we thought we were doing a really good thing. And so it's just really, it's interesting to see how this has changed over time. First, we thought we had to deeply sedate everyone with benzodiazepines. Then we figured out this was associated with poor long-term outcomes. Then we found out maybe we should be using propofol over benzodiazepines. Then dexmedetomidine came into the picture, and we're considering dexmedetomidine versus propofol. Then we have post-intensive care syndrome coming into play. We have Yahya Shahibi showing us that we don't want to sedate people at all if we don't have to. And then lastly, if you come to the very end, we have the COVID-19 study led by Brenda Punn showing how much delirium these patients have that had COVID. So I think this is really just an important picture to think about, and just we've came a very long way over 20 plus years, and we really don't want to regress and be deeply sedating and giving all of our patients benzodiazepines. So going back to our initial patient case, I think this is an important study that I did discuss that day on rounds and did get a change in our sedation, thankfully. But this is a retrospective propensity score matching of patients that predominantly received propofol to those that predominantly received midazolam. So 174 patients received propofol, and they were matched to 174 that received midazolam. And as you can see here, patients that received propofol required less catecholamines, so don't let anyone ever argue with you and tell you should be giving, you can't give propofol because your patient is hypotensive, days 1 to 4 of ICU stay. And the mortality rate was 38% in the propofol group and 52% in the midazolam group after 30 days. And midazolam was associated with ICU mortality. So now that we have discussed all the data that really drives what we did pre-pandemic, what did the pandemic do to us? So this first study I'm going to show you is the association of sedation, coma, and in-hospital mortality in mechanically ventilated patients with COVID-19. So this study is from 7 different ICUs in Boston. They were all mechanically ventilated patients between March and May of 2020. So these patients were propensity score matched. So patients either had ARDS that had COVID or they had ARDS from a different source. So as you can see, in-hospital mortality was higher in COVID-19 patients. They also had more comatose days, and they also had a higher hypnotic agent dose. The hypnotic agent dose was associated with coma and mediated coma, and coma was associated with in-hospital mortality and mediated in-hospital mortality. Their sedation burden index was 3 times higher in the COVID-19 patients, and this was even after adjusting for neuromuscular blockers and proning of these patients. And COVID-19 patients had less delirium and coma-free days, not surprisingly. A second study was the ABCDF bundle during the COVID-19 pandemic. It was a 1-day point prevalence study. So this is a huge study from 54 different countries and included 135 different ICUs with 1,229 patients who met eligibility for this study. So as you can see here, unfortunately it shows performance in non-COVID-19 patients and performance in COVID-19 patients declined during the pandemic, which is really unfortunate. And really none of the levers really have a great number, which is really unfortunate. It also showed that low income status was associated with poor implementation of letters A, C, and D, and also low income status was actually associated with higher compliance with the letter F. So the last study I will show you from the pandemic is the COVID-SED study. So this was a dual center retrospective study that looked at sedation practices over 48 hours. So this, as you can see here, patients either were in the light sedation or deep sedation group, and unfortunately there was a lot more propofol given. There was slightly high midazolam. There's a lot more ketamine. I don't think that's surprising to anyone in the room. A little more fentanyl and a lot more hydromorphone. Deep sedation patients experienced fewer ventilator, ICU, and hospital-free days and increased mortality when compared to the light sedation group. And early deep sedation remained significantly associated with higher mortality after adjusting for confounders. So very scary data. So this really shows, unfortunately, how far we regressed during the pandemic. You can see here that a lot of patients were unfortunately being really deeply sedated. A lot of patients were receiving benzodiazepines, and unfortunately, sometimes that was needed. But I think it's really important to highlight that the pandemic, although we're still seeing some COVID-19 patients, we're not seeing a lot of them, and we can't let that completely change our practice and really just destroy all the data that we have collected over such a long period of time. So what are some strategies to help with the letter C and to overcome barriers, and what can be done to really sustain and to help us maintain all this evidence that we have obtained over the years? So all I can say is re-educate, re-educate, re-educate. Unfortunately, what we have seen from the pandemic is there has been a large leaving of nurses in particular, but also physicians, pharmacists, et cetera. A lot of people were leaving healthcare. So before the pandemic, sure, we were continually have to re-educate as we got new nurses and make sure that everybody knew how to do all these different tools and make sure they knew why we didn't want to use benzodiazepines. But unfortunately now, some of the new hires that we have started during the COVID-19 pandemic, and they think it's normal for everybody to be deeply sedated, and they think it's normal for everyone to be on benzodiazepines, and if their patient moves, then they will deeply sedate them because that's what they learned, and they don't understand it's harmful. So all we can do is continue to re-educate all the different key players and tell them that sedatives do indeed reduce time spent in both slow wave and rapid eye movement sleep. They do not help patients to sleep better. It's also important that we restart pre-hospital medications. This happened to me this past week. I walked in and I was on rounds, and I had a patient that was agitated. And so a team member was like, hey, let's put the patient on quetiapine. And I was like, hey, we need to restart their home meds. This patient's on gabapentin. This patient's is on buspirone. You have to look at their home meds and put them back on that before we're trying to put a Band-Aid on and start them with new medications to make the patient look better on paper. Also, clustering patient activities, so doing things like to help them sleep better at night and not giving them medications or labs that aren't necessary in the middle of the night. Using an sedation approach, we know that if we don't treat pain, they get agitated and delirium, so always treating pain first. Use your clinical pharmacist. I'm not just saying that because I am a pharmacist, but just remember, physicians, I work with physicians that come through the ICU only 2 weeks a year, and we have such a rapid turnover of nurses. Use your pharmacist. We're always there. And also staff wellness. I think it's important to remember that I can promise you, if you show that you're turning off a sedation and analgesia on your patients, and your patient is able to get up and walk around and gets off the ventilator faster, then everyone will want to do this to every patient in your ICU. So in conclusion, choosing the right analgesics and sedatives is imperative to providing the best ICU care. COVID-19 has severely regressed our utilization of light sedation and non-benzodiazepine sedatives. Let us not regress post-COVID-19 and forget 20-plus years of evidence. Re-educate all your staff and use your clinical pharmacist to best optimize the letter C. Thank you.
I don't need any coffee now. I'm awake. I'm waiting for the next slide deck. Thank you. So I drew the short straw. Brenda Punn couldn't be here today, unfortunately, and I will be speaking to you and doing my best Brenda Punn imitation about ICU delirium in the wake of the COVID-19 pandemic. I have no financial conflicts of interest to disclose, and all photos of VA patients were obtained with permission. By the end of this talk, you should have a better understanding of the current prevalence and impacts of ICU delirium, effective management strategies to prevent and treat ICU delirium, and how to overcome barriers to manage delirium in your ICUs. As a refresher, ICU delirium is a clinical syndrome, underlying syndrome, characterized by a change or fluctuation in baseline mental status, inattention, and either disorganized thinking or an altered level of consciousness. The clinical presentation of ICU delirium can vary within and between patients over time. There are 3 recognized subtypes of ICU delirium: hyperactive, hypoactive, and mixed. Hyperactive delirium is easier to detect since these patients tend to be agitated. By contrast, hypoactive delirium is typically characterized by confusion, lethargy, and apathy, and is often overlooked in critically ill patients. This distinction is important because hypoactive delirium is associated with worse clinical outcomes in patients. The causes of ICU delirium are multifactorial and not well understood, but probable mechanisms include susceptibility of the aging brain, neuroinflammation, hypoxia, neuronal mitochondrial dysfunction, systemic inflammation, and neurotransmitter dysregulation. Pre-existing risk factors for ICU delirium include age, hypertension, severity of illness, baseline neurologic dysfunction, and substance abuse. Modifiable delirium risk factors include pain, sedative use, especially benzodiazepines, deep sedation, mechanical ventilation, sleep deprivation, immobility, restraint use, and social isolation. ICU delirium is associated with an increase in ICU and hospital length of stay, an increased risk of PICS in ICU survivors, the need for institutionalization on discharge, and increased hospital and long-term mortality. And all of these bad outcomes are associated with higher healthcare and societal costs. Nearly 2 decades ago, when Wes Ely and colleagues published their seminal article in JAMA to raise awareness about the ICU delirium epidemic. The incidence of ICU delirium in mechanically ventilated patients was greater than 80% and was estimated to be between 20 and 50% in non-mechanically ventilated patients. With increasing utilization of the ICU Liberation Bundle practices prior to the pandemic, the incidence of ICU delirium in mechanically ventilated patients had decreased to less than 50% in many ICUs. But the onslaught of the pandemic brought a catastrophic reduction in delirium monitoring, prevention, and patient care in the ICU due to organizational issues, a lack of personnel, increased use of benzodiazepines for sedation, and restricted family visitation. This resulted in large numbers of critically ill patients, including both COVID and non-COVID ICU patients, who were deeply sedated, lightly monitored, and cared for in understaffed ICUs where delirium monitoring and prevention became a very low priority. Critically ill COVID-19 patients are at particularly high risk of delirium due to a combination of systemic inflammation, neuroinflammation, and thrombosis related to COVID infections, and the effects of deep sedation strategies, benzodiazepine use, prolonged mechanical ventilation, restraint use, and social isolation in these patients. Estimates of delirium in critically ill COVID patients range from 55 to 84%. COVID patients are also more likely to manifest hyperactive delirium, up to 69%, as compared to non-COVID ICU patients. A study by Brenda Punn and colleagues of over 2,000 adult ICU patients with COVID-19 showed that over 90% of these patients required mechanical ventilation, and 64% of these patients received benzodiazepine infusions for an average of 7 days. Over 80% of these patients were in a coma for an average of 10 days, and over 50% were delirious for an average of 3 days, for a total period of acute brain dysfunction of nearly 2 weeks. Delirium in compliance with the ICU Liberation Bundle was also adversely affected. They found that non-benzodiazepine sedation was associated with a 41% lower risk of delirium than with benzodiazepine sedation. Family visitation was associated with a 27% lower risk of delirium, although family visitation, either in person or virtually, occurred only 17% of the time, and bundle compliance across all elements occurred on only 1 out of every 3 days for these patients. So what can we do to improve ICU delirium management and outcomes for our patients? We know that routine use of either the CAM-ICU or the ICDSC assessment tools improves delirium detection and management in patients. The CAM-ICU tool is the most commonly used delirium assessment tool and assesses patients for the 3 cardinal features of delirium: mental status changes, inattention, and either altered level of consciousness or disorganized thinking. It's important to remember that before you can assess a patient with the CAM-ICU tool, that you must first assess their sedation level using the RASS tool. If a patient's RASS score is either -4 or -5, then you're unable to assess that patient for delirium. If patients have all 3 features of delirium, then they're considered CAM positive for ICU delirium. Traditionally, ICU delirium has been managed with a variety of medications, including sedatives and antipsychotics, along with physical restraints. But we now know from the multi-center MIND USA trial that antipsychotics don't prevent or treat ICU delirium. They only help to manage the symptoms of delirium. And sedatives, both sedative type and exposure, are actually a risk factor for ICU delirium. Shahabi and colleagues showed that any sedation in the first 48 hours of admission to the ICU increases the risk for subsequent delirium, and the deeper the level of sedation, the higher the risk. For every 1 point increase in sedation intensity, the risk of patients subsequently developing ICU delirium increased by 25%. The MENS and SEDCOM trials both demonstrated that the risk of ICU delirium is higher with benzodiazepine sedation versus non-benzodiazepine sedation, specifically using either propofol or dexmedetomidine. Only one large study, the MENS-2 trial, has compared delirium prevalence with propofol versus dex for sedation, and they found no difference between two groups. A recent systematic review and meta-analysis by Habadi and colleagues did demonstrate a lower incidence of delirium with dex than propofol, but only in cardiothoracic surgery patients. Stevens and colleagues showed that in the COVID SED study that mechanically ventilated ICU patients with COVID were much more likely to receive benzodiazepines and other sedatives at much higher doses than non-COVID patients. Rasulo and colleagues demonstrated that this approach to sedation in mechanically ventilated COVID ICU patients is associated with over a 10-fold increased risk of these patients subsequently developing delirium. Restraints are commonly used to keep delirious patients from pulling out their lines and tubes, but restraints themselves actually increase the incidence of ICU delirium. A variety of other non-pharmacologic evidence-based strategies can significantly reduce the risk of ICU delirium without the need for restraints. These include effective pain management, minimizing sedative use, avoiding deliriogenic medications, discontinuing mechanical ventilation as soon as it's feasible, mobilizing patients, including mechanically ventilated patients, and getting them out of bed, removing invasive lines and tubes when they're no longer needed, avoiding restraint use, actively reorienting patients, promoting sleep, and engaging patients and family members in care processes. The pandemic created a number of unique barriers to performing the ICU Liberation Bundle and preventing and managing ICU delirium in patients in particular. Work environment barriers included contagion precautions and the use of PPE, increased workload, staffing shortages, and the use of providers with limited critical care training, social distancing that precludes interprofessional team rounds from occurring at the bedside, hampers team communication, and reduces family visitation, and drug shortages that lead to the increased use of benzos for sedation. Patient care barriers included reduced pain, sedation, and delirium assessment in these patients, the use of deep sedation, high-dose opioids, restraints, and paralysis due to fears of isolated patients becoming agitated and pulling out lines and tubes, limited SAT and SPT trial, mobilization efforts, and reorienting patients to keep staff out of the room. Severe sleep disruption and social isolation of these patients ensued. In other words, it was the perfect storm of deliriogenic conditions for patients. Even as the pandemic is now becoming endemic and COVID-related risks to staff and visitors have decreased, many of these delirium management barriers still exist in ICUs. A recent interprofessional survey of SCCM members of their current ICU liberation practices demonstrated that overall compliance with the ICU Liberation Bundle has significantly decreased since the pandemic. Persistent barriers to bundle implementation include staffing shortages, a lack of bundle education, a lack of staff and leadership buy-in and support for the bundle, and poor team communication. Respondents were also asked where their ICUs currently were with implementing best practices for each bundle element. Only 17% of ICUs had fully implemented delirium management practices. About 40% had partially implemented delirium management practices but had remaining challenges, and 30% hadn't implemented any delirium management practices yet. So how do we overcome these barriers to ICU delirium management? During the pandemic, John Devlin and colleagues published specific strategies for performing the bundle in COVID ICU patients. General strategies included having intensivist-led teams of non-intensivists with just-in-time bundle education for team members, cross-training staff to perform various bundle elements like PAD assessments and reorientation and mobility efforts, conducting virtual IPT rounds and using bundle scripts and checklists, and involving families virtually in these rounds. Delirium management strategies included recognition that delirium is present in most COVID ICU patients, reassessing the need for deep sedation and paralysis on a daily basis, prioritizing CAM ICU assessments and reorienting patients whenever they're awake, identifying and mitigating delirium risk factors for patients every day, minimizing sleep disruptions at night by clustering patient care activities, and using antipsychotics only to treat the symptoms of delirium. Several organizational characteristics can also improve bundle performance. The most important of these have been shown to be strong leadership at the C-suite level, a robust safety culture, a collaborative work environment, daily interprofessional ICU team rounding using checklists and goal sheets, and integration of the bundle into the electronic health record. So what are some realistic strategies for preventing and treating ICU delirium in the future? Significant progress is being made towards developing reliable, continuous brain function monitors to detect pain, depth of sedation, and delirium in critically ill patients. Personalized sedation strategies are also being developed to mitigate the risk of oversedation in patients. ICU redesign that focuses on sleep preservation, mobility, and patient and family interactions. And of course, making sure that the ICU Liberation Bundle is delivered to every single ICU patient every day. We know that ICU Liberation can significantly reduce ICU delirium, improve lives, and reduce healthcare costs for our sickest patients. The COVID-19 pandemic has caused major setbacks to bundle performance in ICUs worldwide. But going forward, I am confident that we can accelerate bundle performance in the near future to prevent and treat ICU delirium more effectively. Thank you for your time and attention. Our next speaker will be Christiane Permy, who is the owner of Permy ICU Rehab Seminars and a rehab education specialist at Houston Methodist Hospital. She is a fellow of the American College of Critical Care Medicine. Mrs. Permy practiced exclusively in the ICU for more than 30 years and has extensive experience in early mobility and rehab in the ICU and is truly one of the leaders in this area for ICU liberation. Chris?
Good afternoon, everybody. Thank you very much, Dr. Barr, for the introduction. So we are here today talking about resuscitating the ICU Liberation Bundle following the COVID-19, and it's my great honor to be here to talk about the letter E, that it's early mobility and exercise. I have no potential financial interest to report, and the learning objectives for this lecture is to list 2 consequences of bed rest and immobility, and also list 2 strategies to resuscitate the letter E of the ICU Liberation Bundle. Okay, so here we are talking about resuscitating the ICU Liberation, and the letter E, which in my opinion, it's the most exciting letter of the A to F bundle. I know I'm biased, but I think it's the greatest one, and my opinion, the most important one. So basically, let's just start talking about, is this a new concept? When we talk about early mobility and exercise, more than 70 years ago, in 1940s, Dr. Asher, he published the Dangers of Going to Bed article. And in this article, there's one quote that is one of my favorites, where he says that it's my intention to justify putting beds and graves in the same category. And then, in the 1970s, there were 2 publications that addressed patients who were on mechanical ventilation, and they were ambulatory, and both of these publications really talk about the incredible benefits that provided to the patients. And moving on, in the late 2000s, where we had the first articles that started showing us the scientific evidence that early mobility and exercise in ICU is safe, feasible, improves physical function, it can reduce delirium, and also can reduce the length of hospital stay as well as costs. So after that, later in the 2010s, actually in 2018, the PADI's recommendations were published. And at that time, the letter E was addressed when they addressed immobility for patients in the ICU. Then what happened? COVID-19 hit in 2020. And I'm sure that everybody is well aware that COVID-19 changed the landscape of healthcare. So basically, this article that I'm showing here, it really represents what happened with the COVID-19. So the results of this study are very powerful, in my opinion. So basically, it's a multi-center cohort study that was carried out in 69 adult ICUs in 14 different countries. And that study included more than 2,000 patients. So basically, the results demonstrated that because of COVID-19 and the way practice was changed, sedation was increased, as we have been able to, learn recently here. Also, mobility was suspended. Family visitation was suspended. The median RAS score for patients on mechanical ventilation was -4 in this study. And more than 81% of the patients were in a comatose state for about 10 days. When I look at this, I think this is devastating. And why is that devastating? Because of the consequences of bed rest and immobility. So why should we care about that? We should care because when patients stay on bed rest or immobility for too long, it's going to lead to deconditioning, not recovery. There are very few medical reasons why a patient should be in bed. And anyone who thinks that bed rest is going to solve any medical problem, it does not. It's the opposite. In addition to that, it will lead to profound muscle weakness. This is what I have been dealing with for the past 30 years of my career in ICU. Believe it or not, this is my patient who is 52 years old. I mean, it's basically the skin on top of the bone. And finally, it also leads to significant loss of functional independence. Here I have another young person that in order to take a few steps, it takes 2 staff members holding them up to barely take a few steps. So basically, again, when we talk about the letter E, why should we care? We should care because bed rest and immobility in ICU remain a major issue all over the world. And unfortunately, the practice of bed rest and immobility leads to substantial problems for patients, families, as well as the healthcare system. So now let's talk very briefly about understanding the letter E. I know that there are some, definitions that have been published in multiple, articles, but the reality is that when I ask different clinicians about what do you think it's early mobility, they have different opinions about it. Some may think that, early mobility is PT and OT. Just consult PT and OT and that's early mobility. Others may think it's just, you have to walk on the ventilator. It doesn't matter what it is, you have to walk on the vent. And then sitting on the side of the bed, perhaps sitting in a chair, perhaps out of bed within 24 hours. What about any exercises? What about ICU rehab? So there's this kind of a confusion about, early mobility is just an umbrella term, but in reality, early mobility means early physical activity. What kind of activity are we talking about? Basically, in bed, could be turning side to side, sitting on the side of the bed, maybe doing some exercises in bed, or out of bed exercise activity. That could be sitting in a chair or, in a stretcher chair, which means that the patient does not have the ability to stand up and take a few steps to the chair and then get back into the bed. Also standing by the bedside and taking some steps and walking. So basically, when you look at all of those physical activities that I just listed in here, I want you to understand that you do not need to have a physical therapy license to provide any of those to the patients. And the reason for that, it's important to understand that for physical activity in ICU, it's basic nursing care. If the patients do not have any significant weakness or any kind of functional deficits, if they just need a little help to get up and move to the chair, this is basic nursing care. So we can't really wait until there's a consult for physical therapy and wait for the physical therapist to show up for those patients to be mobilized. In 2021, the Choosing Wisely for Critical Care, the next 5 article was published, and the recommendation number 4 was, do not delay mobilizing ICU patients. And the recommendations were that mobility can be initiated and guided by the bedside nurses, and mobility should not be solely dependent on PTs and OTs. And because the resources for PTs is very limited, as you all know. I mean, we are not, there's not a whole lot of physical therapists in the hospital to begin with, and much less physical therapists that are trained to take care of critically ill patients. So basically, these patients need to be mobilized before we get there. All right, so what kind of strategies should we have to resuscitate the letter E? The first thing, we need to evaluate the current mobilization practice in your ICU. So there's no point in start hiring more physical therapists if patients are still sedated, right? So you really need to look and see what's going on. Also, create specific mobilization guidelines. Obviously, if you work in a trauma ICU versus a cardiovascular ICU versus a medical ICU, those patients have different needs, so you have to have specific guidelines for each patient population. I think one of the most important strategies would be to eliminate bed rest orders altogether and just write them if there is a reason for and justify the need for bed rest so everybody will understand why the patients are in bed. Also, including the E-letter in daily ICU rounds, establish clear patient-centered mobility goals. We have to make sure that we are offering the patient what they are able to do. Now, a lot of times, you know, they want everybody to walk, but not necessarily everybody has the ability to walk, or their strength, or the endurance to walk. So we have to be clear. We can't be telling the patient, oh, the physical therapist is going to be coming here later on to help you walk. And I go there, they cannot even move the legs. You know, so it has to be patient-centered. And finally, we must engage patients and families in the letter E. It's very important. We must give permission for these patients to move. Patients in ICU are scared to move. They are told over and over again when they are intubated that don't raise your arm, don't move your arm, because if you raise your arm, we're going to tie your arm down. Have you heard that before? Now, do you think that after patients are intubated that anybody notifies them that now they can move their arm? I cannot even tell you how many times I will tell my patients to move the legs and lift the legs. They say, are you sure I can do that? I'm sure they're not going to tie my legs. So again, we must give them permission, you know, to move, because a lot of times they want to do that. They just don't do it because they don't know they can do it. All right, let's talk a little bit about letter E, equality. I believe that every patient, every day, in every single ICU in the entire world should have the opportunity to experience early mobility and early exercise. So obviously, when we talk about developed countries, there are, you know, technology, equipment, and all that to help do this. But when you talk about underdeveloped countries, their resources are not there. But that doesn't mean the patient should be in bed. And I love to talk about this friend of mine from Brazil that for more than 20 years, he's been going to the hardware store, he buys the PVC pipes, and he builds those chairs so he can mobilize those patients because there are no chairs in the ICU. So we have to offer the patients, even in low-resource areas, you know, the ability to be mobilized. So what are some simple strategies? Because in reality, Early mobility in ICU is not about how are you going to get the funds to buy this $30,000 incredible technology with electrical stimulation and a computer to mobilize the patient. No, it's not about that. It's about the simple things that make a difference. So for early exercises, this is just like an idea. What about if we expect our patients to do 100 leg lifts or 100 arm raises every day? Not at once, throughout the day. Everybody that walks in, ask the patient to lift the arm or the leg. That would make a significant difference for those patients. As far as early out-of-bed activities, we don't need to be creating a mobility program about who's going to get out of bed. The rule is everybody gets out of bed, except the patients who should not be out of bed, which are going to be very few patients. If they have like active bleeding requiring transfusion, escalating doses of vasopressors, maybe unstable fractures. But other than that, I mean, it's very unlikely that there's a reason for them to be in bed. All right, so what are these strategies? What about if we sit the patients on the side of the bed for vital signs? It doesn't take that long. Sitting in the chair for the meals. I mean, who eats in bed? Sometimes when I tell my patients, you need to get out of bed to eat, oh, I cannot do that. They won't let me do this. You know, those are simple things that can be done. Also, mobility techs in ICU. 5 years ago, the facility that I work, we started having mobility techs in our ICU because there's not enough physical therapists, the nurses are busy. So the program has been incredibly successful. Now we are implementing mobility techs in the nursing floors also. They are hired to do mobility. That's all they do. Now, do you have the budget for that? What they did, they changed the nursing assistant positions to mobility techs. So they are hired to do that. So that's their job. Okay, another simple strategy. This article was just published from a group from Brazil that they just created did a QI improvement. They just put a clock on the wall and with two handles. One was the handle that is the goal for the mobility for the day, and the other one was what the patient achieved. So every person that walks into that room every day has a clear understanding that the patient needs to walk. However, it's 2 o'clock in the afternoon, he's still in bed. So it's visual. So with that, increase the out-of-bed mobilization, increase the daily higher level of mobility, and also reduce the mobility protocol non-compliance and rate. Here are the takeaway messages that I want you to have. Bed rest and immobility are dangerous to patients in ICU. Please do not forget that. The letter E is applicable to adult and pediatric population. I know the pediatric patients are different, but we have to think about the same way and also mobilize those patients. Interprofessional collaboration is imperative for the success of early mobility. Patients must be awake for letter E. Letter E is not equal to physical therapy. And letter E is everyone's job. I'm not telling for anybody that you have to go and get patients out of bed, but just asking, you know, have you been out of bed today? Have you been doing your exercises? Everybody has to be involved. So finally, the time to resuscitate the letter E is now. Early mobility and exercise must be a priority for all patients in ICU. And I think that the theme for the Congress this year is Better Together. So I don't know that there's any better way to say that better together, we need to get our patients in ICU moving. Please. Thank you very much.
That talk may have inspired a run on PVC pipe at the Home Depots. Our final illustrious speaker today is Dr. Jaspal Singh. Dr. Singh is a pulmonary critical care doctor from North Carolina who works at Atrium Health. His clinical expertise is in the area of mechanical ventilation, sleep disordered breathing, and education in critical care. His professional interests lie in understanding how healthcare systems can adapt to physician shortages, including how to incorporate innovation, technology, and team-based care. Dr. Singh.
All right, thanks for having me. It's hard to follow Chris, so bear with me. I get to talk about the most important letter, sorry Chris, the letter F, the family engagement and involvement piece. Mobility is good and all, but I think for the family piece kind of wins. So I think, thanks for the nice introduction, Julie. I'm not going to talk more about that. I do have some disclosures, but hopefully none of this relevant to this talk. And so we're going to talk about family engagement, which is an important piece and it's very personal because I'll talk about my own personal journey through this in the last few years, how things have changed since we last met in person. We're talking about family-centered care, look at some basic principles of guidelines, look at the 2017 guidelines, and then look at pre-pandemic and then post-pandemic, what's changed, what's evolved in this space briefly. And look at some successful strategies moving forward. So we kind of knew this pre-pandemic, right? We knew we had some issues. How many of you love healthcare from a family perspective? No. Most of us is kind of a thumbs down in the ICU experience if you're part of a family, right? We struggled with this for decades. We knew patients were isolated from their families. We had lots of studies to show that. We knew that communication issues were ubiquitous in the ICU, and there were a lot of barriers to ICU visitation. I know many of you in the audience have had, family visitation that was liberal, but for a lot of us who are older and grayer, we remember times where we were kicked out of the ICUs when we visited families, routinely. There were certain hours you had to go, and it was really challenging. We learned about caregiver suffering early in the last couple of decades. This sort of had increased in prevalence and knowledge base. And then we also knew that patient safety and experience matters with now healthcare systems, organizations looking at patient experience in a transparent manner as much as possible, and that's becoming important. So in that space, family-centered care kind of emerged as an important approach towards healthcare that's respectful to and responsive to individuals' families' needs and values. Now, we had a plenary session this morning about diversity, equity, inclusion by our keynote speaker. This is core to DEI work, right? So I have a leadership role in DEI work. So seeing people where they are, their values and everything, this is core to that element. And so what's involved in that? Aspects of collaboration, respect and dignity, decision making, information sharing, all this is part of being truly patient and family engaged. And the SCCM has helped in this process, but people like Dr. Judy Davidson, who's, I think, giving a special session tomorrow about some of these issues, in 2017, led an effort about the family-centered guidelines. And they advocated for a few things: flexible and open presence, the option for families to participate in team rounds. That may not be for everybody, it may be intimidating for them, but the option to do that. Even being present during codes. Now, we just happened to witness, for those who watched that incredible scene in the Bengals-Bills game a couple weeks ago, you can imagine you saw the impact of the people who watched that code happen in real life and how that affected, incredible athletes broke down in front of us on national TV. And you can see what that looks like and how that looks. We were advocating for that a while ago, but we still today don't do that in a lot of our ICUs. But their team advocated for this a while ago. And so they also looked at sort of all kinds of data. They assembled some of the data about some of the education programs, the peer-to-peer in the neuro ICUs, in the neonatal ICUs, talked about educational leaflets, and realized people do this differently. Some people do ICU diaries, some people look at validated decision support tools, but really what came across is a better way to communicate. And this team shows and advocated for what's called the value mnemonic, that they want patients and families to be considered, in order to sort of approach them in a great way, got to think about them in terms of look at the V for value their comments, A, acknowledge the family's emotions, L, listen, U, understand the patient as a person, and E, elicit family questions. And my wife tells me this works really well for teenagers as well. So I've adopted this to my home life, and it works out incredibly well. It's been much more successful. And then the communication, how do you do the communication? So over the course of my life, I've been fortunate to have a lot of mentors who teach me about family-based communication, and oftentimes you still end up not knowing how to move forward, right? We have family conferences, we have structured communication approaches, we have family members of dying patients. Sometimes they don't have a real way to sort of bereave, and so we talked about having real way to grieve, having things like bereavement brochures or resources for them. And then the other ultimate piece is that ICU clinicians should receive communication training. Now, having gone through med school, residency, fellowship, and then training afterwards, you're like, really? Communication training? After all those years of education? And I was surprised at how little many of us get trained, including myself, about how to communicate effectively, genuinely, with empathy. And I think that's something that we'll hopefully revisit in the future, in a future talk. The idea of consultations, having palliative care consultations, almost to the point where I think some places now have gone almost too far, where the palliative care team assumes all communication, and we can talk about that forever. but ethics consultations, psychologist interventions potentially being available, social worker participation in family conferences so we can understand some of the social elements and coordination and needs. Family navigators. So the other turban I wear is in the lung cancer space. In the lung cancer space, we have tons of navigators. Navigators that help coordinate visits, help coordinate testing, diagnostics, procedural results, all those things. In the ICU, how many of you have navigators? But wouldn't that be kind of cool, right? To have someone to help us understand logistics. Where's the family right now? How are they doing mentally, emotionally, and even physically? Where are they geographically? Spiritual support, all those aspects are being thought about how to approach this with more sophistication and ideally more impact. The group also advocated for operational environmental issues, things like protocols to adjust sedation. You heard a lot about that earlier on. But nurses be involved in goals of care. How many have gone to a family care discussion, but without the nurse, only to come back, there's a discordant view of where the patient's at and what values the patient, family, and the team has. Hospital policies for family-centered care, noise reduction, environmental hygiene, this is all important and part of the guidelines. And even family sleep made it to the guidelines at some point. So they also established some goals, and I think the most important one is the first one, is establish a trusting relationship, but also provide emotional support, helping families understand the diagnosis, treatment options, and such. And then allowing patients to be seen as a person. Creating conditions for careful deliberation about difficult decisions, quiet rooms, sort of ways to sort of minimize disruption. And all this was thought about pre-pandemic. Oh, sorry, I need to go backwards. And so in this space, when I teach my residents or trainees or others, we think about different mechanisms of how to get to good patient-family engagement. Family-centered rounds, daily updates, portals, interdisciplinary family meeting, and they're all different. And they all work differently for different people. I don't think any of us really understand which one works better for each individual family. And some of them just have some pros and some cons. Not everyone's perfect. Family-centered rounds is great when the family's present, when they want to be involved and they have good questions and they know how to like sort of work that group. But it can also be awkward for some. It can be inefficient for some teams. Daily updates when you call them every day. Well, sometimes I forget, and it can be an awkward conversation depending on how it's done. Other times it can be great. Patient portals. How many of you have family members with patient portals that have no idea how to navigate? Well, we went through that. That was horrible, right? How do you navigate patient portals? They're not easy. They're not made to be intuitive all the time. And then the interdisciplinary family meetings, oftentimes are a traditional mechanism, but they can be hard to coordinate logistically. And that was pre-pandemic. I did also like this sort of thing of some authors out there had advocated for trying to put a cadence or a rhythm to the family interactions. Start out kind of giving them information, move towards a more systematic interaction, and then as the disease progresses or the complexities increase, things happen, kind of become more structured on a regular cadence. I tried to roll this out to our teams. I just didn't get any traction, but I still want to revisit that. Other teams looked at things like ICU diaries. They looked at sort of the empathy training based on some neurosciences. Even before the pandemic, we were talking about burnout, wellness, resilience in this space, as well as issues of self-awareness, institutional awareness, as well as a larger movement called the compassionate care movement, which I'm part of. And how many of you had COVID lavender in your teams? Or how many of you have Schwartz rounds? As I get older, those are the best rounds that I really enjoy, to be honest with you. I mean, I like important database information, but I find that oftentimes those shared spaces, those safe spaces, those brave spaces, some people call them, are oftentimes very helpful. Julie and the team also led things like the Liberation Minimum Data Set. The idea is, can we measure some of these basic things that families need? So we started collecting some of this data in our ICUs and other ICUs around the country, and started thinking about, what things are important, what are must-haves, what are nice-to-haves in most ICUs to be good at patient and family engagement. And I'm not going to go through these. These are all sort of publicly available. And then the pandemic hit, right? And the earth just stopped, right? We made all this momentum, all this energy towards patient-family engagement, and then all of a sudden, as you kind of heard earlier, and many of you experienced, right? I had to wear a PAPR every day to work. I had to manage patients and families, talking to them virtually. People couldn't hear me, couldn't see me, and then they couldn't really understand what I was saying all the time at work. It became a very difficult time for a lot of us. And in that journey, I learned a lot about this space that I've been speaking about before the pandemic, but I got to see it from a different lens through those last several years, especially that first year or so. And a lot of us were trying to figure out, should we allow families back? And I think a lot of us said, yes, we should allow families back at the bedside, but, hopefully safety. And there's a bunch of reasons why we should let them back. And a lot of us debated this for some time. I like this sort of really long, and I apologize for the font in this room. I didn't realize we were in this big room. I thought it'd be a small little room that we'd be speaking in. And, but we talked about sort of the different reasons to do that. I think the reasons are listed here. But the idea of psychological distress for the families was way up there. I mean, it's really hard. How many of you had family members, have COVID? Well, I went through that with my parents in the ICUs with COVID. I didn't know what's going on. Nobody would talk to me. I couldn't get anyone to communicate with me effectively. That was very distressful. Then we also had basically family members and, the physical and symptoms. The family actually couldn't really help a whole lot with these things, and we also ourselves had psychological symptoms. The PTSD, the psychological grief of the pandemic, the lockdown, the effects of it had on the entire family were just immense. And then there's issues go on and on. The impact was enormous. And I think for all of us, it was just extraordinarily hard. I think many of us are still unpacking all that went through. I know many people have moved on. Some have had a hard time because of how hard it was. And so I'll just sort of say that for a lot of us, we really want to get family members back in the ICUs. And I know it was hard. And as we come through, I know pockets of our country are having surges again, and we have to revisit these policies again. But it's adding a whole lot. I did want to touch on a couple of points which I would think none of us were prepared for. One was we talked about the importance of trust and trusting relationship, but the infodemic, the information aspects of how we had to manage what was scientifically felt to be valid or recommended versus what the patients and families felt. We struggled with that piece quite a bit. We didn't really have a formula or data to understand how to manage TikTok information and YouTube information versus scientific literature. Like we wrestled with that so much. And so a lot of that became something else, another skill set we had to learn to sort of go through. And that was tough. The unkindness that occurred in that space, violence, aggression towards healthcare workers. I mean, those are things that, honestly, as much as we've had some challenges, I don't remember to that degree having to manage some of that stuff. And some of that's still present today, as you all know. So we're starting to think through some of those aspects and how can we manage those a little bit better. And so the authors of this article actually thought of some strategies. For example, is if we have time constraints, we can't update families. Can we think about navigators, whether that be a separate person or actually just someone on the team can help manage some of that? Miscommunication. I've sometimes called the wrong person virtually or hit the wrong iPad button or somebody else answers the phone. How do we manage information issues in the virtual world? We started thinking about other ways to communicate and thinking about newer technologies. Now that we've understood virtual technologies better, can we really understand that and make it easier to plug and play these things? And I think there's a way. The aspects of confidentiality and stuff like that we're still wrestling with, but the idea of additional access, and I think now that cell phones and technology and the public is aware of virtual technologies more than ever, I think we're hopeful that we can actually leverage some of the virtual technology to help patients and families engage better in the future. I like this study a lot published earlier this year, and also was on SCCM podcast on the website. The idea, this author actually went ahead and gave surrogates of non-decisional critically ill adults who had a high risk of mortality and basically did summaries of the patient's illness daily for the family. And the investigator did the summary, not the primary clinicians. Pretty exhausting on his part, but it was interesting to me that in 2 weeks, the anxiety, depression, acute stress scores from the family, from the surrogates, actually improved intervention. I just think about that quite a bit because I wish someone had done that for me when my father was sick in the ICU or my mother was sick in the ICU, or my friends. For those who don't know, India got decimated during the pandemic, and I'm at daytime wearing a PAPR, working in the ICU, at nighttime managing WhatsApp and ventilator waveforms at night. So I'm up all night thinking about these things, and no one's really telling me what's really happening. It's extraordinarily stressful. And so the family engagement, just as we finish up, basically is something that we're still learning There's promising solutions like new virtual tools, new options, but no single recipe for success. I would say there's an urgency now, as I think the overall sort of climate in the country has changed, where patients and families want to trust their healthcare workers, and we have to, I think we should allow that to happen, but we have to prepare for that and do it. To do that, you have to have some sense of urgency, and I would say make it personal, and think about new ways of thinking of this. Think of a continuous journey. There's a lot of creativity out there, and the SCCM has a great number of talent, a lot of talent out there that wants to start thinking about ways how to approach patients and families differently, knowing what we know now. Measure. The minimum data set's great. Maybe it's outdated. Maybe we have to think about different ways of thinking about the space. And then I would say share your stories. Tomorrow morning we get the treat of, in the plenary session, to hear two fantastic storytellers of our lifetime, Drs. Glock and Flock. And who's going to go to that session? I mean, even no matter what you think about social media, the way they tell stories is just so impactful. And so I encourage you all to tell your stories and start thinking about what are other ways to impact so that we can have the resources and the bandwidth and the methodologies to really drive home patient family-based care. Thank you very much.